One of the other things that we're presenting at this meeting is the responsiveness to PARP inhibitors, specifically olaparib, based on the type of gene mutation that a patient has. So 2 or 3 years ago, when the first publications on olaparib and other PARP inhibitors started to come out, we were under the impression that prostate cancer patients that had BRCA2 mutations, but also BRCA1 and ATM mutations, a third gene, would all be sensitive to PARP inhibitors, including olaparib. And in fact, when the FDA designated a breakthrough designation for olaparib in prostate cancer, the breakthrough designation was for prostate cancer patients with one of 3 genes, either BRCA2, BRCA1, or ATM. So over time, the field has begun to understand that, yes, in the case of BRCA2 and BRCA1, the responses to PARP inhibitors are going to be quite high, maybe 50 to 80%. But one of the things that we are increasingly appreciating is that ATM perhaps will not be such a favorable biomarker for response to PARP inhibitors. So one of the posters that we presented at this meeting, and which other groups are confirming, are that prostate cancer patients that have either germline or somatic ATM mutations really don't have the same degree of PSA response, objective response, or progression-free survival compared to patients with BRCA2 or BRCA1 mutations that receive olaparib. So in our data, we looked at our institutional experience at Johns Hopkins, and we classified patients as having a BRCA1 or BRCA2 mutation into one group versus an ATM mutation into a second group. And we asked the question, how effective is olaparib in patients that have BRCA1-2 versus ATM? And in our experience, the PSA responses in ATM patients were basically 0 in our group of patients, whereas in patients with BRCA1 and 2, the PSA responses were above 50%. And then when we looked at progression-free survival and overall survival, the patients with BRCA1 and 2 had much longer progression-free and overall survival compared to those with ATM. So the data is beginning to emerge, perhaps suggesting that ATM-mutated prostate cancers will actually not respond as well or as long to PARP inhibitor therapy. Now, there might be some good news for those patients. There is data coming out from phase 1 clinical trials that tumor types that have ATM mutations, not just prostate cancer, but all tumor types, these tumors might be very sensitive to a new class of drugs called ATR inhibitors, which is another DNA repair pathway inhibitor. And so, on the one hand, although these patients may not respond to PARP inhibitors, the ATM deficient patients may actually respond to a brand new class of drugs called ATR inhibitors. So this will be an exciting thing to keep our eyes out for.